require more of the upper body than the deconditioned, untrained arm is ready to handle. So the analogy that I've been using for a number of years now that I like a lot for this is heart attack and shoveling snow. So if you have two individuals, they both have a heart attack, and one goes to cardiac rehabilitation and does supervised, slowly progressive, controlled increase in physiologic stress on their damaged body system, in that case the myocardium, and the other person does not do that, and the next winter it snows, and both of them go out to shovel their walk, which one is more likely to have a second MI? Okay? So the basic idea is that this might be an analogy for what happens with lymphedema and lifting a heavy object, because the truth is that women live their lives, that women have purses, that women find themselves and backpacks. Have you seen mine? And you know that women have children. My children weighed more than 8 pounds at birth, you know, and women used to be told that they shouldn't lift anything heavier than 5 to 10 pounds ever again in their lives. So, you know, so you want to say, okay, so where's the prescription for the personal valet who's going to carry, you know, everything for me? A gallon of milk weighs 8 pounds. You know, how many of you have been at the last gate at the terminal and the wheel on your suitcase breaks? You know, I can tell you other stories that are true stories from the participants in my trials. The woman who went to buy the Christmas tree, and the guy was just way too busy, so she decided to put the Christmas tree on the roof of her car herself. Holiday shopping, the most common time of year that we had flare-ups in the trials that I've done have been at the holidays, because women are carrying a lot of bags. They're shopping for the holidays, carrying a turkey at Thanksgiving yesterday. Yeah. It's really supposed to be in November, but that's okay. You get right. So, sorry. That really was a joke. Yeah, I was corrected yesterday. Apparently your Thanksgiving happened well before ours, so I'm sure that's true. Anyway, so the truth is that women are going to use their arms, right? They're going to use their arms. So you have a choice. You can either have women go through a supervised program of slowly progressive, controlled increase in physiologic stress on that arm, thus improving the ability of that arm to withstand inflammation, injury, stress, trauma, okay? Or you can have them decondition the arm and say, don't use the arm, and then they find themselves with their 3-year-old nephew who ran in the street, and they have to pick the kid up, and then they come in and say, look at my arm, it's a balloon, okay? Those are your choices. So that's what we started with, based on, as I said, standing on some very broad shoulders. So WTBS was funded by the Susan G. Komen Foundation. This was weight training for breast cancer survivors. It was an RCT on weight training. We only had 14 women with lymphedema in the trial. Lymphedema was, in fact, a nuisance variable in this trial. I was mostly interested in looking at breast cancer recurrence risk factors, the IGF and insulin axis. But there we were. We had to recruit, and we needed to include women who had lymphedema in order to reach our recruitment goals. The intervention occurred within a laboratory setting, the University Recreation Center. So it was something where at the end of the study, the women who were in the study did not have access to the facility after the end of the study. Okay? The lymphedema outcomes paper was an important piece in the changes from the National Lymphedema Network in guidelines for exercise and lymphedema. And that was published in 2006 and garnered a great deal of media attention. The New York Times published an article with a horrible title of something like "Balancing the Desire for Exercise with Painful Swelling." Yeah, what did you think of? Me too. So, yeah, a terrible title. Anyway, other media attention. I had hundreds of emails and phone calls and contacts saying, where do I go to get this program? There was no way to disseminate it to other survivors. We had, the staff were research assistants who worked for me. One of them went off to the Peace Corps. One went to do her PhD in nutrition in LA. they were gone. There was no way that we could disseminate this. There was no way to sustain the program itself for the participants because these breast cancer survivors, most of them had never done strength training. They finished the program, and then I said, well, go to the gym and keep going. But they didn't recognize that the lat pull-down machine looked different but did the same thing in a different gym. That's not their base training. They didn't understand that, and we didn't have the resources to help them. So based on that, when we were funded then through the long-term survivorship initiative from the National Cancer Institute to do the PAL trial, we decided we wanted to address some of that sustainability issue. We wanted to do something that was a one-year randomized controlled intervention with twice-weekly progressive strength training versus a non-exercising control. This is a much larger trial than the prior pilot with 288 breast cancer survivors, and we wanted to do it within a community setting. We wanted to do the intervention in a way that would allow at least the women in the study to continue exercising after we were done with the study. And our hope was that we would then be training trainers out in the community to be able to deliver this intervention to breast cancer survivors who came after them and were not a part of the trial. Okay? So we did measurements at baseline, 3, 6, 9, and 12 months. Half of the women entered the study with lymphedema. Half of the women entered the study at risk for lymphedema, having had lymph nodes removed in their treatment. The women without lymphedema were 1 to 5 years post-diagnosis. The women with lymphedema were 1 to 15 years post-diagnosis. So just to be a little bit more pedantic here, this was really, the PAL trial was really 2 trials in one. We had 2 primary outcomes and 2 cohorts. So I think you can see can you see the arrow? Yeah, you can see it. So in trial 1, our goal was to recruit 144 women with lymphedema and to randomize them into 2 equal-sized groups. One group would do the twice-weekly strength training, one group would not. And our primary aim here was to address the question of the safety of strength training, slowly progressive physiologic increase in stress on the affected arm, to make sure that it was safe for these women to do that kind of activity. We were just going for safety. That's it. We just wanted to be able to say these women are allowed to do this type of exercise. Okay? But in the same way that exercise for treatment is going to be different than exercise for prevention when we're talking about heart disease or diabetes or lymphedema, the second part of the trial, our goal was to recruit 144 women who were at risk for lymphedema and to randomize them into 2 equal-sized groups, strength training versus nothing, and to follow them over a full year. And again, the primary outcome here was it safe for these women to do strength training? And for both groups, the primary outcome was a 5% change in interlimb difference, because that is the clinical threshold at our institution and in many places where you finally say, hey, something's changing here that's a big enough change in arm swelling that we think we might need to do something clinically. We need to start looking at this person more carefully. Whether we're ready to diagnose lymphedema or not is a clinical decision, not just based on that number. So here's what the women looked like at baseline. So we were nearly successful in our recruitment of 144 women with lymphedema. We got to 141. And you can see that their interlimb difference in water volume, so for those of you less familiar with this measurement, this is basically a large lucite tank, and you dip the woman's arm into the tank all the way up to a measured line in the armpit, and then you do the same thing on the other side. And you take the volume, the water volume of the affected limb, and you compare it to the unaffected limb, and you look at the percent difference between the two. And what you can see is that the women who had lymphedema coming into the trial, on the left side of this trial, of this slide, in the treatment group had a 15% interlimb difference, and in the control group had a 17.3% difference. I'm not including p-values and measures of variability on these slides in interest of just having cleaner slides, but that was not a statistically significant difference at baseline. The standard deviations were larger than 3 or 4%. And then for the women who did not have lymphedema, you can see here that we overshot the mark a little bit for recruitment, first off, 77 in each group. And they really had, negligible differences in interlimb difference at baseline. So they honestly did not have lymphedema when we started the trial. And they were pretty much the same. So one of the issues here is how do we go about ensuring the safety of these participants in this trial and in the pilot before it? We did a telephone pre-screening. We also did an in-person pre-exercise evaluation by trained measurement staff and then by a certified lymphatic therapist. And if there were questions about whether the woman had lymphedema or not, she was sent to the certified lymphatic therapist. If she was determined to have lymphedema, then she was randomized within that part of the trial. If she did not, then she was randomized within the no lymphedema part of the trial. Okay? So we also, for all of the women who had lymphedema or developed lymphedema, we provided them free of charge custom-fitted compression garments from BSN Medical, or JOPST. You might know it as JOPST. And we also obtained written physician clearance. So you can start to see, with this long list, think about trying to implement this within your clinic and how much work this would take and how many people it would take in order to provide this kind of screening to do this kind of program on an ongoing basis. It's not scalable. It's not scalable. So how do we monitor symptoms ongoing? Well, the trainers did that. They would ask every week, do you have any change in symptoms? And if there was a change, then they were sent in for measurement by our measurement staff. And then, if necessary, if there was an honest change, they would be sent to the certified lymphatic therapist for evaluation and potential treatment. There was an obvious centralized system funded by the grant for referring women back to free physical therapy evaluation and treatment. So they didn't even need to worry about whether their insurance was going to cover the cost of the evaluation and the treatment. The intervention itself was started with 13 weeks of supervised exercise twice weekly in small groups, no more than 6 survivors per trainer. The non-attenders were called to say, hey, where were you? We need you to get back in. One of the lessons learned in this project was how vitally important it was to have regular attendance. The women who had problems were more likely those who attended irregularly and thus were stressing their arms in a way that didn't allow us to train the arm. All of the trainers were trained by me in a 3-day intensive training to deliver this intervention. The goal of that training was to teach them the protocol and to put the fear of God in them about the possibility that they could be putting these women in harm's way, and that if there was a problem, they'd better call me. Okay, that was my goal. So, and I showed them lots of pictures of huge blown up arms and so they women would, their first sessions, they were very tentative, and that was what I wanted them to do. So, and then 9 months of unsupervised training. The trainers continued to monitor whether the women were coming to the gym and looked at their logs and called them if they weren't showing up. Every month, the women were invited to come back to the gym to get safety measurements and were allowed to have once a month personal training sessions. All of this paid for by the trial. Kind of a Cadillac intervention. Okay, so they came. They actually showed up. Even in Philadelphia, they were adherent. So, the joke is if you want to do difficult interventions, you need to do them maybe in Canada and certainly or in Minnesota or Iowa, in places where there's a well-educated, stable population. But they actually showed up. 88% of the sessions that were prescribed were completed in the lymphedema group and 79% in the no lymphedema group. So good on them. They did a good job. So here's what happened. They got a lot stronger. I'm showing you here the slide with the strength changes in the women with lymphedema, and in the interest of time, I'll simply tell you that the similar effects were seen in the women without lymphedema. There were about 30% increases in upper body and lower body strength as measured by a 1-repetition maximum test, which in over 500 women in my research and Anna Schwartz's research has been shown to be safe in breast cancer survivors with and at risk for lymphedema. And what I can tell you to put this in context is that in a prior R01 that I did in younger women, called this the SHE study, Strong, Healthy, and Empowered, the changes in these very same parameters were about half as much. So clearly these older women and breast cancer survivors stood to gain quite a bit from being a part of a strength training intervention. So this was the big splashy result. This slide is showing the big splashy results that netted me a New England Journal paper last August.